Welcome to Arch Ghost, the show focused on creating high caliber, adaptable, and prosthetically driven full arch surgeons. The surgical techniques described and depicted in this podcast are provided by Arch Ghost LLC solely for informational and educational purposes and are intended exclusively for properly trained, licensed, and clinically competent healthcare practitioners acting within the scope of their professional credentials. As a licensed healthcare practitioner, you alone assume full responsibility for all clinical decisions, actions, and outcomes as part of your patient care. Please see our full legal disclaimer at archghost.com/disclaimer. Whose fault is a failure? So today, I wanted to talk about a touchy subject that is, not often an easy one to discuss, especially for those of us who are in a referral relationship. Now, those of you, that do your own surgery and your own prosthetic or your own restoration, a little bit easier pill for you to swallow because there's not a lot of people you can point the finger at. But for those of us either in a private practice, referral relationship, or in a full arch style center where there's a surgeon and there's a prosthodontist or a restorative doctor, this can be a touchy subject when an implant failure occurs. And I wanted to talk a little bit about, in my opinion, and, the prosthodontist that I worked with the past 3 years, we talked about this a lot, and he, shared these views for what it's worth. I don't want you to think that this is just, a surgeon ranting. But I think this is an important topic to talk about, especially for those of us that are in that referral relationship. So, when we, when we do a full arch surgery, and let's say, something comes back at the 4-month mark, you're doing your integration check, and there's an implant that failed. Traditionally, in these situations, in my experience, the surgeon is approached and told by the restorative provider, and this, is not any one provider or any one situation. This is just kind of my experience across the board, and in speaking with colleagues in private practice, this is the same scenario. And the restorative provider approaches the surgeon and says, hey, you have an implant failure, whatever, number 20 failed. So this has always pushed my buttons because, in my opinion, the approach to this situation should be, hey, we have an implant failure. Patient so-and-so presented at their 4-month appointment and implant number 13 failed. As the surgeon, I feel that at that point, there are a couple of things you need to look at on your end and assess that failure, and we're going to talk about those. But also the restorative provider, there's a few things they should be assessing on their end and looking into why the failure occurred. I think that mind shift of, hey, surgeon, your implant failed, to, hey, our implant failed, is really key in preventing the next failure. Because if you are only looking at surgical reasons why that implant failed, you're missing really 2/3 of the reasons why that potential failure occurred, and you will then neglect changing those things and preventing it from occurring again. So, really, when we talk about implant failure, there are 3 parties involved, right? We have the surgeon. That's kind of an obvious one. We have the restorative doctor. You'll often hear me say prosthodontist, because that's often who I'm working with, but this is anybody who's doing the restoration. And the third one we have is the patient, right? So these are the three parties that ultimately contribute to whether an implant succeeds and integrates or fails. Now, the difficult thing is that these are all interrelated, right? It's hard sometimes to just point to one or the other because they're so intertwined. However, we can break down a couple of key areas that each of these parties is responsible for, and understanding those areas can really help facilitate the diagnosis of why an implant failure occurred, how to correct it, and how to prevent it from occurring again. As the surgeon, there are a couple of things that I'm responsible for. All right. In order to increase the odds that that implant's going to succeed. The first thing that I'm responsible for is AP spread. Okay. This is different than the cantilever. AP spread is the distance between your anterior and your posterior implants. Maximizing AP spread is my job. Now, there are times where that's easier to do and times where that's harder to do. But being able to maximize it within the realistic confines that the patient presents with is the job of the surgeon. Okay. Now, my goal as the surgeon is to achieve an AP spread that in the anterior, that anterior implant position. And in order to think of this, rather than think of a number, 15 millimeters or 12 millimeters or 20 millimeters, really I think of the implant position because that's really what's important. In the anterior, I want those anterior implants exiting around the cingulum of the incisors. If you are able to achieve that, you will have minimal to no anterior cantilever because of your implant position in the anterior. In the posterior, I want a second bicuspid implant position or better. Again, with a 1 molar prosthetic, you're going to have a 1 tooth or less cantilever in that situation. Now, AP spread, again, I want to clarify, is not the same thing as a cantilever. But if you can put your implants in a position where you're at that second bi and you're at that cingulum, the resultant AP spread will be very strong and will be able to tolerate the cantilever that is produced. But AP spread, this is the job of the surgeon. Okay. Second job, CTV or composite torque value. So really, torque, right? This is obviously the job of the surgeon. The restorative provider can't do anything to affect the torque. The patient can't do anything to affect the torque. Only the surgeon can affect the torque of the implants. This is something that comes with experience. This is one of the biggest differences between a surgeon that's done, 2, 3, 4, 500 arches and somebody that's done 2,500 plus. In my experience, the surgeons that have done a few thousand arches can consistently generate high torque, and that makes a difference in the case. Those that have less experience haven't yet developed that feel when they're drilling to know how to optimize the osteotomy or the implant selection. That comes with time, and that's okay. It just comes with time. But this is something that is very valuable that, as a surgeon, you should work to increase your ability to consistently generate that torque. So the surgeon, again, is responsible for these two things, AP spread, composite torque value. Now, if we go back to that diagram of surgeon, restorative provider, and patient, I want to go to the second party involved in that scenario, and that's going to be actually the patient, okay? Now, the patient does have a role in the success of their prosthetic and their implant integration. And they really contribute also in two key areas. The first area is soft diet, okay? typically in our practice, we do a soft diet for 4 months, okay, until the implants integrate. That, as far as I know, is the industry standard. I'm sure some people have slight variances in that, but most providers, regardless of where you practice, are doing some type of soft diet for 4 months or around that time period. Now, a blatant disregard for that diet can lead to implant failure and can be a causative factor in lack of integration. That being said, I think that while this is a factor, it's one we place too much emphasis on. And the reason I think that is because I ask patients when they come back at the 4 months, or the prosthodontist, typically is honestly the one to ask this question, but I asked the prosthodontist what they said. We asked them how long they followed the diet. The average patient will say 8 weeks. That's the average. Some patients 4 weeks, some patients say never. I'd say only 1 in 4 patients or less actually follow that diet for 4 months. So what that tells me is that soft diet probably isn't as necessary or as important as we think. That being said, nobody wants to say not to do it, and myself included. But I think that, oftentimes when there's a failure, we all want to say, and I'm guilty of this too, well, the patient was eating before they were supposed to. Maybe, but what about, the other 50 patients we talked to that, started eating at 4 weeks and they all integrated? So I don't know that this is, I think this is a factor, but I think this is a scapegoat that we all use as a means to say, well, it wasn't my fault. The patient ate. So I challenge you that while we should acknowledge this, and you should encourage your patients to do a soft diet, at least it seems that way, don't let this be the reason you think your implants are failing. The second component here is hygiene, right? So these are really the two areas that the patient can impact the prosthetic. Hygiene is very similar to diet. Hygiene is something that is necessary. I just saw a patient a couple weeks ago that we had seen a year prior, everything integrated. She did great. She came back. She had 2 implants on the lower with, 50% bone loss, purulence on both sides, swollen, painful. I ended up electively removing them. They were integrated, but I did remove the implants. We moved to a different site, cleaned out the infection. But the patient told us she doesn't do any hygiene. I mean, she's not doing anything. It's been a year. So, in that scenario, that is likely the reason that she had those issues. That being said, again, I think it's easy for us when we have an implant failure to say, oh, well, the patient wasn't performing proper hygiene. Hygiene is important. There's no doubt about that. But you can also look at so many patients that have had a successful 4-month integration and didn't do any hygiene or did very poor hygiene. So again, the challenge here is these are areas that we need to acknowledge with the patient, but I challenge you as the surgeon or the restorative provider, this shouldn't be the first place that we look. And I think it is always the first place that we all look. We all want to point to the patient didn't follow the diet or the patient didn't do hygiene, and that's why there's a failure. And the reality is it can occur, but it's probably not the first reason why there was a failure. All right, so we've talked about the surgeon. We've talked about the patient. The last party in that circle is the restorative provider. Okay, this can be, sorry, I can't talk and write at the same time. The restorative provider can be either a general practitioner, a prosthodontist, whoever's doing the restoration. Now, I saved this one for last because I think this is the most often undervalued and underassessed reason as to why there is an implant failure. And I think that it is very often the most likely causative factor. Now, I know I'm going to get a lot of hate mail out there probably from restorative doctors, but I want to say this. I'm not saying this in a way to point blame at anybody. It's quite the opposite. I'm saying this in a way that the restorative aspect, the prosthetic aspect, is extremely important. It takes an extreme amount of skill to do well, and it has a very high impact on the surgical outcome and the success of the procedure. So I'm saying this out of a position of respect, that this part of the procedure carries a lot of weight. There's always focus on the surgery side, but this side really demands just as much focus. And I can tell you, I have had the pleasure and blessing of working with many very talented prosthodontists that have taught me a lot, that have made me a better surgeon. And when I work with doctors of that caliber, I can tell you that my surgical results, my integration rate is higher. My failure rate is lower. My patient satisfaction is higher. I've worked with some restorative providers that aren't, as experienced and well trained, and I can tell you that I've had more failures, more complications, less happy patients, and so this is a side that is important. The areas that I feel, we talked about 2 areas that the surgeon is responsible, 2 areas that the patient is responsible for. With the restorative provider, I also feel that there are 2 areas. So the first area is occlusion, all right? Now, this sounds obvious, or I hope it sounds obvious, but the restorative provider, is the doctor responsible for the occlusion of the prosthetic. This is extremely important. It baffles me sometimes how little emphasis is placed on occlusion by some providers. And, one of the areas that I see this commonly in is with my OMFS colleagues in private practice who do this procedure and restore it themselves. And in their defense, because the referral wants nothing to do with it or doesn't feel confident in doing it, so the surgeon has to do it. But, as surgeons, we have little understanding of occlusion typically. And this part of the procedure is just so key to the implants integrating and healing well. And, in that setting, it's done maybe with, not the attention that it deserves. Now, I'm not going to go into, an entire lecture on occlusion, nor am I an expert on occlusion. That's why I work with prosthodontists. But I can tell you that when you place a poor occlusion or a malocclusion on implants that are trying to integrate, that is a recipe for disaster, a recipe for failure. Just think about it. You've got implants that have yet to integrate, and you're putting an off-axis, unbalanced, high, force on that implant repetitively. It's going to fail. And when I see cases that have more than one implant failure, 2 implants, 3 implants, a total failure, to me, that screams occlusion. It's unlikely that there was a surgical reason, that unless you drilled every osteotomy without irrigation and overheated the bone or something, ridiculous, for every implant site to have an issue, that is a force issue. There's a force being generated throughout the prosthetic that is unfavorable. It's either occlusion or it's the patient, is chewing hard candy at week 2 or something. But that again is just, we have to understand that the occlusion we put on those implants will make or break them. Incredibly important. The second aspect that the restorative provider is responsible for is the cantilever. Okay? Now, you're probably going to say, well, Matt, you just talked about AP spread. You said the surgeon was responsible for AP spread. The surgeon is responsible for AP spread, but the cantilever is different. The AP spread is the distance between implants. The cantilever is the unsupported distance that comes after the implant. This is both in the anterior and in the posterior. The restorative provider is the one that has the full control over the cantilever that is placed. Now, again, I can hear people saying, well, I don't have control over that. If the surgeon only gives me this, what choice do I have? You always have a choice. You always have a choice. You are given a product by the surgeon. You have the unfortunate blessing and curse of going second. So you have to react to what the surgeon has done. You choose whether or not you place a 3-tooth, a 2-tooth, a 1-tooth cantilever, or a no-tooth cantilever. Now, that decision isn't always easy. If you have a product from your surgeon that is poor, you have to make the decision of, do you tell that surgeon, I can't work with this? And, you need an additional implant. Hopefully that decision's happening intraoperatively. If it's a referral to you, that becomes a little more complicated. The other option is things like downsizing the arch to a smaller arch size. There are pluses and minuses to doing that, like tongue space and other things. It's not always an option, but you may have to go to a smaller arch size, or you may have to drop a tooth. Maybe you drop a tooth just during the integration period. Maybe you drop a tooth, permanently. Maybe you drop one on one side, not the other. But those are things that are in the restorative provider's control. And that decision is ultimately made by the restorative provider. If the decision is made to ignore the cantilever and just move forward, that's a recipe for disaster. Now, this is a team effort, okay? Yes, the cantilever is the restorative provider's responsibility. However, the surgeon, if the surgeon is not consistently providing an AP spread that is adequate and that produces a 1-tooth or less cantilever, then there's an issue also on the surgery side. So this is a team approach, okay? I'm not saying one person is responsible solely for that altogether. But ultimately, the point being is that the restorative provider, again, it's a blessing and a curse, but they go after. You go second after the surgery. You have the final decision on what you're going to do, how you're going to respond to the product that the surgeon provided you. Now, here is where this becomes valuable. So I want to bring back this photo or drawing. Now that we know the roles of each provider, when you have an implant failure, this is what you need to see in your mind. This circle: surgeon, restorative provider, patient. And you need to go through those responsibilities. So in my practice, when the prosthodontist comes to me and says, hey, we have an implant failure, the first thing that they do is go to assess the occlusion. Was something off on the occlusion? The second thing they do is assess the cantilever. Was the cantilever too big? Or even if it wasn't too big, is there a cantilever that we feel could have played a part, and what can we do to reduce that cantilever? On my side as the surgeon, I say, thank you for informing us that we had an implant failure. I'm going to assess what were the torque values on that case. I can't go back and change them, but I can say, I had 60 torque at 3 sites and 25 at 1, and that's the one that failed. Okay, this was likely a torque issue, and, we're going to redo the surgery, and how can we remedy that? Or, I had 60 plus torque on all the implant sites, so torque is clearly not the problem. It's also a process of elimination, right? The other aspect is, on my end, is AP spread. So I have to look at that case and say, was AP spread adequate or not? Again, the response provides us information either way. I might say, you know what, that case didn't have great AP spread and we knew it, but we loaded it anyways. Now, the redo surgery, I really need to be cognizant, whether it's a pterygoid or whatever, about eliminating any cantilever by maximizing the AP spread. Or I might say, you know what, AP spread was phenomenal and we really didn't have a cantilever, or we had a very acceptable one. And then that points to the fact that AP spread was not the issue. And then last, we look at the patient and we assess, is the patient performing hygiene? We talk to the patient about what diet they were eating, and we take all of that information into account. The key being that the patient is the last aspect, and in our opinion, the least likely to have caused the issue. It is possible, but it's usually not the issue. And then we work together as a team to figure out where that problem is and how we can remedy it. Sometimes it's very clear, other times it's not, and we may have to guess at a couple of those items and try to fix both of them. But, really the key take home that I want to get across to you is that, whose fault is a failure? There are three parties involved. The least likely is probably the patient. You need to look at both the restorative aspect and the surgery aspect as a team, and you need to understand the surgeon's responsible for torque and spread. The restorative doctor is responsible for occlusion and cantilever, and you have to take ownership of those aspects, address them, and then fix what's necessary. I think that simple shift in mindset, both in understanding that it's our implant, but also in understanding your roles. When you know what you're responsible for, you know what to fix, and that's ultimately the key. So I hope that helps and didn't create too much tension. But I think that's the pod. And as always, remember, operate in the shadows, adapt relentlessly, and load them all.